Hi and welcome to PhysioTutors podcast, episode 71 with Dr. Annina Schmid. Annina is a specialist musculoskeletal physiotherapist, a professor of pain neurosciences at the University of Oxford, and the head of Neuromusculoskeletal Health and Science Lab at the Nuffield Department of Clinical Neurosciences at Oxford University. She has published over 100 papers with a primary focus on nerve entrapment neuropathies, which is the topic of today's episode. Hi, Annina. Welcome to the podcast.
Thank you. Thank you for having me.
Yeah, it's an honor. And as always, I've prepared quite a list of questions, so let's jump right in. And my first question to you is, can you maybe explain what entrapment neuropathies are and how they typically present in patients?
Yeah. So entrapment neuropathies are basically just conditions where the nerve is compressed or irritated as it travels through narrow anatomical spaces. Typical presentations are carpal tunnel syndrome or cubital tunnel syndrome, but it could also include painful cervical or lumbar radiculopathies, so more distal or more proximal presentations. Quite often, clinically, the presentations are sensory, so that means patients have pain, often more nerve-related pain as well, which can include tingling or numbness sensations. But in some patients, it can also involve motor changes, for example, weakness or reduced reflexes.
Okay, and you already mentioned a couple of examples. What would be the most common types of entrapment neuropathies and which nerves are mostly or most frequently affected?
Yeah, the most commonly affected ones is the median nerve in the carpal tunnel, and that is followed by the ulnar nerve at the elbow, so cubital tunnel syndrome. Then is the radicular pain problems, lumbar more common than cervical radicular pain. And then there is much less common entrapment neuropathies such as Morton's neuroma, tarsal tunnel syndrome, thoracic outlet syndrome. And then there's the more debated kind of diagnosis, for example, Piriformis syndrome. Does it exist? Does it not exist? What exactly happens? So this is probably about the order of frequency or prevalence.
Okay, I had that question prepared somewhere, but now that you mention Piriformis syndrome, I'm curious about your take on it. What's your opinion? And I'm sure you know quite a lot about the literature. Does it exist, or is it more of a myth?
Yeah, the difficulty with Piriformis syndrome is, of course, that diagnostically we often can't find very clear signs. But that is actually not only the case in Piriformis syndrome, right? That is actually a problem in many, many conditions. And I would say simply because we can't detect something with the quite crude tests, quite frankly, that we often do in clinic, doesn't mean things don't exist, or doesn't mean the patient is making things up or it's all in their head or things like that. I'm quite strongly against that notion. I would say rather it's probably us that are not good enough at the moment medically to try and understand certain problems. Does Piriformis syndrome exist? Theoretically, I think a nerve can absolutely cause symptoms without us being able to detect anything specifically, especially proximally, where it's very difficult to find something specifically. Our diagnostic tests like imaging are not great at the moment to detect especially minor nerve problems. So I would say it can exist, but of course the difficulty comes that if we do not have a specific test to diagnose it, we have to basically just incredibly sure that it's not something else and that it's basically a leftover diagnosis in a way. It's a syndrome in the end, right? It's a syndrome that is characterized by many different kind of puzzle pieces that come together, and importantly, the exclusion of many other things.
Yeah. My take on it, and we have made a video on this and also wrote a blog about it, is that patients often read about it and think they have it. And if you look closely, then often it turns out to be something else. So,
absolutely.
Not saying that it cannot exist, but I think it's probably far less prevalent than what a lot of people think.
Oh, I absolutely agree. And, quite often, even lumbar radicular pain very often presents like what people think might be piriformis syndrome. You get buttock pain, you get pain when you start stretching the piriformis or whatever. It can be many other things. And I fully agree with you. I think that's why it's so important that we exclude other things first before we think about a syndrome in a way. Yeah.
Okay, moving on, what are the primary causes or risk factors associated with entrapment neuropathies?
Yeah, the primary cause is compression or irritation of the nerve, and that comes because of narrow spaces. It can quite often be idiopathic, so think about carpal tunnel syndrome. There's not usually a reason, it just comes in some patients develops slowly. But of course, there could also be very, very kind of sometimes traumatic reasons for narrowing of spaces or degenerative reasons. So think about disc degeneration, for example, narrowing a foramen and irritating nerve rods. So it can be quite diverse, but overall, it's usually if things get narrow and if the nerve starts to get compressed or inflamed. In terms of risk factors, being female is a risk factor. Think about carpal tunnel syndrome, for example, pregnancy as well, so hormonal risk factors. Increased body mass index is a risk factor for different types of entrapment neuropathies, including carpal tunnel syndrome. Pre-existing systemic neuropathy, so if your nervous system is already more vulnerable, so if you have diabetes, for example, if you have hypothyroidism, you're much more likely to have carpal tunnel syndrome as well, or cubital tunnel, etc. There are certain occupational risk factors. Nice studies in butchers have a much higher prevalence of carpal tunnel syndrome because they use hands very frequently. Genetic risk factors, definitely. We and others have shown that, for example, carpal tunnel syndrome has quite a strong genetic risk factor. And especially we found that genes that are related to connective tissue build seem to be very important. So if you have changes in the genes that are responsible for your connective tissue, that seems important. And of course, that could have to do with how the connective tissue builds a tunnel where the nerves have to go through. But also we have a lot of connective tissue inside the nerve. So if that connective tissue is changed, that might also make nerves more vulnerable.
Okay, clear. And I think a challenge that we as clinicians always have is to differentiate a peripheral entrapment neuropathy from a nerve root entrapment. And I know there's different places where this can happen, but are there some general rules how we can differentiate the two conditions?
Yeah. I think the most important one is probably the pattern recognition. So it's a puzzle piece of many things. I don't think there is one single test that best distinguishes, say, cervical radiculopathy from carpal tunnel syndrome. So the first thing is obviously listen to patients, right? Distal entrapment neuropathies very often have slow onset. They come gradually over time. Quite often patients cannot say it was exactly on Easter Monday when it happened. Whereas if you have radiculopathy with radicular pain, for example, quite often there is an acute onset. So that is often a distinction. So the other thing is bilaterality. Of course, that can happen with nerve root problems, but it's much less common. But it's very common in carpal tunnel syndrome to have bilateral symptoms. But again, that by itself is not a perfect distinction. Look for aggravating, alleviating factors. So, for example, shaking the hands helps in carpal tunnel syndrome, but would not help in a radiculopathy or radicular pain. Whereas putting your hand on top of your head is very typical for, say, a C7 radicular pain presentation, that it alleviates symptoms, but would not alleviate symptoms in carpal tunnel syndrome necessarily. Think about, movement provocation tests that you're doing. So, can neck movements provoke it versus wrist movement? Think about, Fallon's versus Sperling test, these kind of things. Again, these are not perfect. So you cannot just use the Sperling test and say this is a radiculopathy. It might well be just a facet joint problem, right? That is positive on a Sperling. You could use nerve palpation. This is particularly useful for distal entrapment neuropathy, cubital tunnel specifically, quite sensitive on nerve palpation. whereas you would not usually find the ulnar nerve in the cubital tunnel sensitive necessarily in a radiculopathy or radicular pain. But these are all, puzzle pieces that you put together. The easiest is probably if you have a neurological deficit. Then it's actually quite simple to differentiate a nerve root from a distal entrapment neuropathy. So, for example, if you think, a distal nerve trunk problem should make problems or neurological deficit in the peripheral innervation territory. So think about median nerve injury. Versus the root should make problems in the dermatome, myotome, or sclerotome. So, for example, if you identify a weakness in the extensor hallucis longus muscle, this could be C8 nerve root or could be radial nerve, distal nerve trunk. So what we then would do, for example, for motor loss, we would test C8, but not radial innervated muscles. So, for example, flexor pollicis longus, which is median innervated, or abductor digiti minimi, which is ulnar innervated, but both are not, both are C8 as well. If they are weak, then it's likely C8, because it's very unusual that you have median ulnar and radial abnormal, unless this is a more systemic neuropathy. And then you can test radial, but not C8 innervated muscles. So, for example, extensor carpio radialis, brachioradialis, they are radial muscle innervated, but not C8. If they are weak, then it's likely a more the radial nerve, because several radial nerve innervated muscles are weak. This just shows you that you kind of need to know your neuroanatomy. And I'm not saying you need to, remember these in your head and memorize them by heart. But it's good to have these charts ready in your drawer if a patient comes in, so that you can actually try and make sense. Does it fit to a peripheral nerve distribution, or does it fit to a sensory nerve distribution? And of course, you can then double check that with your sensory examination, because of course a C8 problem should have the sensory deficit in a very different area compared to a radial nerve problem. So the radial nerve would be the loss over the dorsal aspect of the forearm and into the dorsum of the hand, and the C8 is the ulnar aspect of the forearm and radiating into little and ring finger. So actually the sensory examination for neurological deficits quite often can help you make sense of the puzzle as well. And of course, we have diagnostic tests, right? So electrodiagnostic tests are really quite good for identifying carpal tunnel syndrome, MRI quite good for radiculopathies, etc. So diagnostic tests can help you as well if needed. But I believe the puzzle is the important thing.
Yeah, I think you answered like 3 questions that I had in one answer. And the motor innervation, I'm always trying to remember that, and then a couple of years later, I'm like, oh yeah, I forgot about it. I should look it up again. Different grips, and there are special tests as well, like the Frohman sign, yes. I think, and all of that stuff. And how reliable do you feel is the area of innervation? Because there's been quite some discussion about dermatomes not being like we see them on textbooks, and also you mentioned stuff like carpal tunnel syndrome giving symptoms in both hands, actually. So how much of a help is that still to look at the sensory area?
I think what we often forget is to distinguish what are we talking about when we're talking about dermatomes. Are we talking about loss of function, so nerves not sending enough pulses, or are we talking about gain of function, nerve sending too many pulses? Dermatomes are really good for loss of function, very reliable. Myotomes as well, really quite reliable. If you have an L5 nerve root problem, you will find that problem in that big toe. Yeah, just yesterday had a classical patient with a drop foot, like proper L4 kind of distribution. Yeah. So they are very good with loss of function. And the sensory deficits usually follow really very classically that dermatomal area. But what really the dermatomes are not very good is for the gain of function distribution. So where the pain is, where the tingling is, where the hyperexcitability is. So they are not very good for that. So we cannot really trust those dermatomes in terms of where is the pain distributed exactly. So for example, just because a patient has symptoms in the whole leg, including the calf and the front of the shin doesn't mean he doesn't have an S1 radicular pain, for example. So we cannot rely on symptom distribution in a dermatome necessarily. Literature suggests about 2/3 of patients do have distribution that does not fit the dermatome. But it's actually really good for loss of function tests, so for your neurological bedside tests. So we shouldn't discard the dermatomes fully.
Okay, yeah, thank you for your clarification. I think that's interesting for a lot of listeners to hear, for sure. And I read about your description of the description of your research group, and there you mention the word deep clinical phenotyping that you're doing for people with entrapment neuropathies. Could you maybe explain what this entails and whether that is also something that clinicians can apply in practice, or if this is more of a research thing?
Yeah. I mean, deep clinical phenotyping basically is comes from the biological constructs, right? So we can do genotyping, we can do phenotyping. So genotyping looks at the patient's genetic code, and phenotyping looks at the observable presentation of a patient. So, for example, blue eyes would be my phenotype, for example, for my eye color. So deep clinical phenotyping means basically very, very careful, very detailed understanding of a presentation of a patient. This comes very much from research, but of course, that includes things that clinicians do on a daily basis. In fact, I think we are experts in deep clinical phenotyping. We understand a patient's social phenotype, psychological profile, biological and biomechanical components as well. This is deep phenotyping in a way. But of course, while we can do deep phenotyping at bedside, in research we involve more specialized measures as well. So we can involve advanced neuroimaging, for example, phenotyping exactly what happens inside the nerve. We can evaluate biosamples. For example, we often use skin, nerve samples, blood samples, looking at proteomic profiles, metabolomic or transcriptomic information. We can look at specialized neurophysiological methods like microneurography or threshold tracking, etc. So we try and collect a lot of information from the same patient because we believe that this might help us to understand differences in presentations within the same diagnosis better. So we are basically interested whether we can identify certain patient subgroups that are more similar. Let me give you an example. So in research, for example, a lot of studies are, especially in physio research, a lot of studies are often done pragmatically. So in a way, probably even a bit simplistic. So it's, can we give treatment X for patients with diagnosis Y? Yeah, so can we do traction for patients with cervical radiculopathy? And of course, these studies, sadly, mostly fail, So they show usually no effects, or at best very modest, small, potentially clinically non-meaningful effects. So these kind of approaches, especially in entrapment neuropathies, has very clearly failed. These are often very large-scale studies. They are very expensive to do, and then we don't get much out of it. Now, we believe that part of the problem is that it's probably an oversimplification to just treat patients with very different presentations, even though they all have, say, sciatica, with exactly the same method. We believe that's not quite what we should do. So deep phenotyping can look at patients in more detail, and we can find potential specific subgroups that we think are more similar, for example, in terms of mechanisms, biologically, so like in social or psychological profiles. We could also try and see would they benefit from certain treatments better if we group them much more carefully. So the advantage is, of course, that with deep phenotyping we can get much more granular information in single patients and a much more in-depth understanding of the presentation. But of course, the disadvantage is that this is very time-consuming, and it's also it needs a lot of expertise, which not every group has. And it needs innovative study designs because, of course, we cannot easily collect very large numbers of patients using a very deep phenotype. The pain field very much is moving towards deep phenotyping rather than just blockbuster treatments for one treatment for everyone, because we just know this has failed, right, in a way.
Okay, and you also mentioned on the page the word precision physiotherapy, which I assume would be like the follow-up of phenotyping.
Exactly.
So if you know more about a patient, you have more precise treatment. How would that differ from the traditional approaches for treating entrapment neuropathies? So, or maybe my question is, has your group figured out something how we can be more precise in our treatment approaches?
Yeah.
And I know you already mentioned there is no cookie cutter approach, which is clear, at least for us, maybe not to all of the listeners out there, but could you maybe talk about precision physiotherapy and what you figured out?
You're absolutely right. I think the precision physiotherapy is probably a bit of a catchy term, and of course comes from precision medicine, right, which is at the moment absolutely where the field is trying to move towards as well. Whether we will be successful in the future will show, but certain things already show very big promise in the medicine field.
Yeah.
So in physiotherapy, I give you a simple example. I think that probably, especially for physiotherapists, is quite intuitive. If I think my patient has a nerve disorder, quite often physio, the first kind of treatment that they think about is neurodynamic treatments, right?
Yeah.
Physio think, okay, nerve problem means neurodynamic treatments. So that might be well and right. But I guess you and me and many others have probably observed in some patients with nerve problems, you can give neurodynamic treatments and you think they're actually very well designed, etc., and patients have absolutely no effect. Or in fact, they get worse as well when they do that. So when we look a bit at the literature specifically for neurodynamic treatments, it's actually quite intriguing, because the studies that have been done have actually been done in a very carefully phenotyped patient group. Just that people often forget about that when reading the studies. But when we, for example, looked at patients or studies that used neurodynamic treatments for patients with sciatica, and we looked very carefully, what kind of patients did they actually include in these studies? It is that these studies include patients who have either a positive straight leg raise or a positive slump. So all these patients have neural mechanosensitivity as a mechanism. Most studies, in fact, I think only one study most studies except for one, excluded patients with neurological deficits. And that's very important, We actually have at the moment absolutely no evidence that neurodynamic treatments have any effects in patients with neurological deficits. But we have quite good evidence with, of course, some problems with bias, small sample sizes, etc. But the studies seem to point very much in the same direction, that there are good effects of neural mobilization if given to patients with nerve mechanosensitivity.
Yeah.
So I think that's a good example of, do we actually have to give these treatments to a much more specialized type of patient? And of course, to understand which treatment to which patients, we need to understand two things. We need to understand what is the mechanism or the dominant mechanism at play in a patient, say nerve mechanosensitivity. But then we also need to know what is the main mechanism that our treatments address. So does aerobic exercise address neural mechanosensitivity or not? Does neural mobilization address neural mechanosensitivity or not? Would ibuprofen address neural mechanosensitivity or not? Right? So in pharmacology, people understand, right? They know this drug has exactly this effect, hence we give it to this and this. But in physiotherapy, it's actually quite amazing how little we understand how our treatments actually work. So that's why our group tries to do the both things. We try and understand exactly what happens in patients. We use a mechanistic approach in terms of phenotyping. But we also try and understand how do interventions work? Which mechanisms do they best address? So for example, at the moment, we have a study running looking at neural mobilization given to any patients with carpal tunnel syndrome. And then we see what is the mechanism of these treatments? Can it, for example, improve microstructural changes in the nerve? Can it induce remyelination or not? Can it reduce sensitivity? Can it reduce mechanosensitivity of the nerve? Does it change the inflammatory profile or not? Yeah, so these kind of ideas, yeah. We are still a bit away from it, but that's what we hope to achieve. Yeah.
Okay, and do you have some answers about what it actually does? Because that's also a common patient question, I feel like, about what am I actually doing?
Yeah. Absolutely. And quite often we kind of then start to fuffle around, isn't it? And don't quite have a good answer. Yeah. I mean, neurodynamics, quite interestingly, apart from probably aerobic exercise in the context of nerve problems, is probably the best studied kind of intervention in a way, therapeutic intervention. What unfortunately, we have very little knowledge in humans what exactly they do. There's quite a bit of knowledge from animal models. And in animal models, it seems to be that it has quite a strong anti-inflammatory effect, locally as well as systemically. And it seems to have an effect on, for example, remyelination and prevention of axon degeneration or regeneration. So these are potentially very desirable effects. But quite interestingly, in animal models, most studies use quite aggressive tensioners. So it is quite questionable, can we translate that knowledge to humans where quite often or historically people have mainly used sliders. And where sometimes tensioners, especially for certain acute presentations, are often not tolerable as well. Yeah. So it's quite a jump from an animal model to a human. That's why we try and do this work. We have just done one study in humans so far where we used T2-weighted imaging, MRI scans. T2 is sensitive to water content. And we have basically shown that this was a very mechanistic study, just 1 week of nerve and tendon gliding exercises of the wrist in patients with carpal tunnel syndrome. And we showed that this could reduce the water inside the median nerve. So likely a reduction of edema, and edema most likely a correlate of inflammation. But we are now in our new study looking at with much more specialized MRI techniques exactly what happens microstructurally to the nerve when we use neural mobilizations.
Okay, yeah, very, very interesting stuff. And besides neurodynamics, are there any treatment approaches that look promising? Because I feel like if you have a patient with a nerve problem, the options that we have are sobering, so to say, because nothing really has huge evidence or shows strong effects. It's often like, okay, education and making the situation as bearable as possible. So next to neurodynamics, is there anything that you feel like is promising or that does seem to have a good effect?
Yeah, exactly. I think you actually describe it very well, right? It's an area where it's not so easy. This is not like an ankle sprain that has generally just a very good natural history, and maybe physio sometimes it's just kind of seems like it's the effective factor, but in fact it might just be natural history often, right? So that is not always the case with entrapment neuropathies. Natural histories are not so great. In fact, about 50% of patients with carpal tunnel syndrome get worse or remain the same over time. So that's not great. It's a 50-50 chance. With sciatica, kind of the dirty group of sciatica, 30% of patients will develop chronic pain. That's huge, right? How do we treat them? Again, I agree with you. It's no one-size-fits-all approach. This has failed, right? We cannot do that. We do not have treatment X for sciatica. We simply don't have it. Personally, I distinguish mechanistically. So I definitely distinguish those patients who have predominantly nerve mechanosensitivity, because there we have really good studies, as I mentioned. So there is good evidence that neural mobilization helps in those patients that have nerve mechanosensitivity. So I think I would definitely target that. I also distinguish patients who have neuropathic pain, because not all patients with nerve problems have neuropathic pain. But those patients that have neuropathic pain, I do believe, probably need a bit more additional help than just physio. So I think about, for example, pharmacological support in these patients. Think about a patient with unbearable neuropathic pain in the leg, burning, tingling, wakes up at night, cannot sleep, is already there for 2 months, is not going away since the acute stage. This is definitely where we would start thinking about or would think about neuropathic type medications. If we have a patient with a neurological deficit, again, my treatment might look completely different. Yeah? So this is another mechanism, it's the loss of function mechanism. In those patients, of course, if they have a very severe neurological deficit, they should not even stay with me, right, in a physiotherapeutic clinic. They might have to have a referral, especially if we talk about nerve root problems, to an orthopedic surgeon, for example. If it's, however, a mild neurological deficit, yes, they can stay in my clinic, and we would monitor them very carefully to make sure they are not progressing in their neurological deficit. So my treatment changes in a way in terms of making sure we are monitoring and making sure we are safety netting these patients, making sure they know that this takes time, that there's not a quick fix to that neurological deficit, etc. So I very much go mechanistically in a way and try and target to the main mechanism. But as you said, I think the main thing is education, right? These patients need to understand what is going on. For that, we need to be confident and understand what is going on so that we have good models to help them understand their problems. Nerve-related problems, especially neuropathic pain, is very difficult to understand for patients. It's very difficult to know why, if I'm sitting here and I do nothing, all of a sudden I get a massive cramp and electric shock in my leg. This is very scary. And in fact, helping them to make sense of things can be incredibly therapeutic as well. And also helps manage expectations, because people often are used, if I go back to the example of an ankle sprain, people are used that things get better within 1 week or 2 weeks, the normal kind of healing. But in nerve problems, especially neuropathic pain, this is not the usual healing. The usual healing is much more prolonged than in these more musculoskeletal problems. So we need to be sure that patients are on board with us in terms of what can we expect, how long does that take, what happens, etc., what can help. Also, what other options are there? Because sometimes physio is not the only thing and sometimes not the right thing as well for these patients.
Okay. Hey, going back to the neurodynamics, I have one more question about it. Do you feel like we should first treat the site of entrapment to create space, so treat the outlet before we do neurodynamic techniques? Or does it not matter? So because I feel like there's some theories that you should first create space for the nerve to move through that narrow space where it gets compressed before you do those techniques. What is your opinion on that?
It's a very good question. So in research, we have very little idea because it has simply not been looked at much. There is a recent systematic review that came out in regards to carpal tunnel syndrome interface. So this would be carpal bone mobilization, stretching of the ligaments, which I'm very skeptical that you can do that. But anyway, this is what the studies did. Versus interface versus more sliding, and that seemed to be comparable, but it's very few studies. Interface alone was better than sham, so it seems to do something. So we don't know quite. It's probably the answer in humans at the moment. Biologically, I would think if you can decrease the pressure and if you can make space, I would think biologically that's the most logical thing to try and do first. So I'm thinking about, carpal tunnel, we know a splint works quite well, right? So we avoid these end range positions where we know the pressure increases. So especially in mild, moderate carpal tunnel syndrome, night splinting can be quite effective. So I think it's a no-brainer to then try and do that. Also in patients with acute nerve root problems, I would certainly, the first thing I would try and do is try and unload. It's a bit like, I call it first aid. So you try and not irritate it, right? It's like you would have a fresh irritated wound. You would not constantly press on it. You leave it a bit alone. So that might mean finding positions where patients are relatively comfortable. That might mean slightly asymmetric sitting. That might mean, certain positioning that they can take on when it gets quite bad. So these kind of things, I think, make a lot of sense, especially in the acute stages. If you have more chronic things, then probably things start to shift a bit more where maybe the creating space is not just the main problem anymore in a way.
Sense.
But this is all, I'm talking now empirically and from a neurobiological kind of background in terms of what happens or what would make sense. But we don't know, apart from those carpal tunnel studies of what is better in humans.
Okay. Yeah, it does make sense what you mentioned. So, yeah. Hey, and at what point would surgery be the best option, or at what point should we refer for possible surgery?
Yeah, I mean, surgery definitely has a place, right? And I think, I remember when I was a first kind of early graduate, you kind of have this proudness, right, of physio being a conservative treatment, and we can avoid surgery, etc. But this is not what happens, right, in nerve problems, and surely not in other problems as well. But there is definitely a place for surgery in some patients, and that doesn't mean physio has failed, right? It just means it's the kind of treatment that would be the right thing for that patient at that time. So certainly, if there is serious pathology, so think again about presentations from the spine. So if you have caudal equina syndrome, definitely, that is not treated with physiotherapy, acute caudal equina syndrome. Severe neurological deficits, absolutely, needs to be at least checked by an orthopedic surgeon. Again, if you think about, a drop foot, an acute drop foot, absolutely needs to be looked at by a surgeon. Progressing neurological deficit, if a patient comes to you, has today an M5 still on the foot, for example, but next time they come have an M4 and it starts to get weaker, that needs to be looked at surgically. But also uncontrollable pain. So in nerve root problems, but also carpal tunnel syndrome, right? If we give it a good go at physiotherapy, and I usually say, at least 6 weeks of really good treatment, see whether we can influence anything. If we cannot influence anything, and the patient feels the way his hand is just not, is not giving him enough of the quality of life that he needs, surgery is absolutely indicated as well. Yeah. So it's patient's preference. And of course, there needs to be a surgical correlate, right? The surgeon needs to have something that they can operate. Yeah.
Okay, great. I think this is a pretty good segue to the next question. Also, if we talk about progressing or progressive loss of function, your group studies entrapment neuropathy also as a model to study nerve repair and injury and repair. What have been the most surprising or significant findings from this research so far? And maybe to link it to the progressive loss of function, how well do these lesions recover? Yeah, so in terms of nerve repair, what we have often used is the model of, or the human model of carpal tunnel syndrome, because it's quite an accessible model. We can do quite careful phenotyping in these patients, including phenotyping of structures. Yeah, so we can look at the nerve in detail using advanced imaging. We can use skin biopsies and look at how the nerve regenerates. In terms of nerve repair in patients with carpal tunnel syndrome, what we find is that surgery, and we use surgery as a means of inducing nerve repair, because you technically take the pressure away and that should induce nerve repair. And what we find, and these are patients with chronic nerve injury, is that the nerve definitely recovers, right? Symptoms go away, so gain of function improves, the pain goes away, etc. But the nerves actually struggle to re-innervate properly. So they have a bit of re-innervation, but they have not full re-innervation. Now, that means if nerves are chronically compressed, the ability of these nerves to fully re-innervate is limited. That is, of course, why quite often, if people have acute drop foot, you don't want to hang around, right? You want to decompress as soon as possible if you want to decompress, simply because you want to avoid very chronic axonal damage. So once axons are damaged, regeneration is slow. It can still happen, but slowly. But I think what is much more interesting, what we find most recently, and in fact that paper is just in the final stages before publication, is that if patients have a chronic entrapment neuropathy, this time we use Morton's neuroma as a model system. Is a compression neuropathy or entrapment neuropathy in the foot of the plantar digital nerve. And in these patients, sometimes the surgeons decide to operate that nerve out because patients have so much pain and it's not controllable. Now, that obviously means we can take the whole nerve and we can look at it molecularly and histologically at cellular level.
And what we do find in patients with chronic Morton's neuroma, so this is not an acute injury, but these patients have 2-3 more years of pain, we find persisting, non-resolving inflammation inside that nerve, which is really quite surprising if you think, because, if you have an acute injury, yes, you have inflammation, but the normal tissue healing would be such that within 2 weeks, the peak is reached and the inflammation starts to resolve. And within 3 months, things are pretty much back to normal. You will not find immune cells anymore in those tissues. But that is not the case in entrapment neuropathies. You will find in Morton's neuroma consistent low-grade inflammation in a nerve. And we actually find that specific types of cells, of immune cells inside the nerve, seem to be associated with patients' pain. And so that's quite interesting in a way. Because it means, but it also raises question, right? Because we know anti-inflammatories, yes, work, but work very short term, like steroid injections. They work for 3 months and then things come back again. So that could be because the space is still too narrow, but it could also be because the type of inflammation that we actually find inside these nerves is not the type of inflammation that reacts to anti-inflammatories. It's probably more the type of inflammation that would benefit from pro-resolving strategies. And that is very much where the pharmacological field is currently trying to move, is can they give medications that rather than suppressing inflammation can turn the inflammation into a resolving type of inflammation. And so this is where we think at the moment it might be quite interesting to work towards also in entrapment neuropathies. Yeah. I hope that gives a lot of information, but I hope that gives a bit of a flair of the type of work that we are currently doing more from the biological perspective.
I think it's a very, very interesting field for sure. And further talking about your research, you guys use ultra-high field MR neurography.
Yeah.
What is that? And how do you think it will influence the future of diagnosis and treating entrapment neuropathies?
Yeah. So ultra-high field MRI is basically just a much stronger magnet. Yeah. So we are using a 7 Tesla magnet, which now has actually been approved for human use in clinics as well. So these are magnets that are much stronger. If you have a stronger field strength, you can get much more detailed resolution in your images. Just think about taking an image with a camera that has just very low resolution versus very high resolution. So your pixels are smaller, which will be better. So we can see much more detail. And obviously, if we have small nerves, more detail helps. And neurography, so MR neurography, is basically advanced sequences that are specialized to show nerves. We can do MRI sequences that are very good for cartilage, MRI sequences that are very good for the brain. And since probably, the last 10 years has been a lot of push to have better MRI sequences specifically for nerves. Now, personally, I think there's high field, so 7 Tesla scanning has now approval in humans. I think it will be limited for nerve imaging, especially for very specialized sequences like diffusion imaging, because there is a lot of artifacts at very high field strength. There's a lot of distortions that comes because the magnet is too strong in a way. But I do think MR neurography itself will be very much a clinical thing, and in fact already has started to be. For example, very complex brachial plexus reconstruction surgeries. These often already use very specialized MR neurography sequences that exactly can demonstrate where the nerves are, where the injuries are, and so to help them plan the surgery. Okay, yeah. So this is already happening. And it's just a matter of time, really, till these more specialized, for example, diffusion sequences will be used in root problems, will be used in cubital tunnel syndrome, etc. And I believe they will be used because these sequences seem to be much more sensitive to detecting nerve problems than our routine T1, T2 weighted images. So, for example, there's some studies in patients with lumbar radicular problems where traditional imaging shows nothing. And there seems to be a hint that these advanced neuroimaging methods like diffusion imaging seems to show changes inside the nerve. And I think that makes sense, right? Because when we do routine spinal imaging, we basically look for a disc abnormality, and does that disc narrow the foramen or not. But we're not actually looking what happens inside the nerve. But of course, the problem is inside the nerve, right? So if we can image inside the nerve, I believe that will be much more sensitive in understanding nerve problems. Yeah.
Okay.
But this is, I would say, probably 5 years, maybe to 10 years till it will be more clinically used. Yeah.
Okay, hey, we are slowly approaching the end of our podcast. So one of my last questions is, if you have 3 takeaways that you would like to share with the audience to remember when it comes to diagnosing and treating entrapment neuropathies, what would they be?
Yeah, in a nutshell, this is always quite difficult, isn't it? But let me try. So let's say for diagnosis, I hope today as well, I made my opinion at least clear that I think entrapment neuropathies are very heterogeneous. So I think for diagnosis, we should try and understand what type of entrapment neuropathy. I don't think we should just happy to say, oh, it's sciatica. What is it actually? Is it a radiculopathy? Is it radicular pain? Is there neuropathic pain or not? Is there nerve mechanosensitivity or not? Because that can guide our treatment. For treatment, one takeaway is, probably the most important thing at the moment until we have better treatments is to make sure patients understand what is going on. As I said, nerve pain, especially neuropathic pain, can be very scary, and sense-making often can be crucial. Also to help manage expectations so that patients don't think, oh, if it's still here after 3 weeks, things have failed. It's actually quite normal that after 3 weeks, symptoms haven't resolved fully, say in an acute radicular problem. In research, a takeaway, I believe, and maybe that's a bit playing the devil's advocate, but I would probably say we should be a bit braver and we should probably reconsider the value of a one-size-fits-all trial approach. I personally really think this is very tricky, costs a lot, is very unlikely to be successful and bring us anywhere. So we should think much more carefully, how can we come up with much more innovative approaches rather than doing one trial after the other. Most of them will fail, I will predict. I think researchers have probably most work to do to try and help find better types of interventions or more targeted interventions for helping clinicians make better decisions as well.
Okay, yeah, great stuff. Hey, we discussed a lot of things. Is there anything that we haven't touched on and that you would like to add?
Yeah, that is an interesting question. I mean, I would probably say, nerve problems is often for therapists can be quite a scary thing, right? And of course, there is some scary nerve problems, if a patient has very severe presentations. So I would say try and understand the problem. If you cannot understand it or if you think something is not quite right, always good to get a second opinion, from your colleague that might be more experienced, that has worked more closely with nerve problems. But also, there's no wrong to refer to your surgical colleagues, GP colleagues, etc. So if it is difficult, then do that. But try and go through very strategically, right? Can I try and make sense of that patient presentation? And if I can, and if it fits, then de-threatening sometimes is the key for the physio, but also for the patient. Yeah.
Okay, and lastly, where can people find you if they want to reach out and learn more about you?
So people can find me mainly through my Oxford website. So if you look up the Nuffield Department for Clinical Neurosciences and the Neuromusculoskeletal Health and Science Lab, there is also a website, although I have to say I'm not very good at keeping it very up to date, but it's www.neuro-research.ch, where we have upload some of our papers, etc. Of course, you can find our work on PubMed. Most of it is we try and do open access as well. And on Twitter, you can find me again. I'm a very passive Twitterer, but I will share, some of our work and papers there. But it's Annina with double N-I-N-A, B Schmid on Twitter. That's probably the channels that I'm using. But as I said, I have to warn you, I'm trying to stay a bit away from social media because it's just taking so much time.
And feel free to share any interesting papers that you think would be valuable for the audience, because then we can put it in in a podcast transcript.
Fantastic. I'll send you a few links. Absolutely.
Okay, perfect. Yeah. Annina, thank you so much for your time and for your knowledge. And it was a pleasure to have you on the podcast.
Thank you very much. And thank you for the really interesting questions as well for me. So thank you.
Yeah, you're welcome. And also to everyone out there listening to this episode, thank you so much for tuning in. And as always, to listen to other episodes in your own language even, including German, French, Spanish, Italian, Portuguese and Dutch, download our new and free PhysioTutors app. And additionally, you can access the transcript and infographic for this episode as well and find more useful physio content. And as always, if you enjoyed this episode, hit the subscribe button or follow our podcast as well on Spotify or Apple Podcasts, and consider leaving a review if you really enjoyed it. And with this being said, this was Kai for PhysioTutors, and I'll talk to you in the next episode. Bye.